eyes closed. Now, the neurophysiology of coma. To maintain consciousness, a person requires intact pontine reticular activating system, number one. Number two, an intact cerebral hemisphere, or at least part of a hemisphere. What does it mean if the pontine reticular activating system is dysfunctioning? Patient may become comatose. But regarding cerebral hemisphere, if there is a unilateral damage or a lesion in the form of a stroke or tumor or whatever, and the other cerebral hemisphere is intact, usually the patient is not comatose, until and unless what happens that in case of a stroke or tumor, there is so much surrounding edema and midline shift and mass effect that it compromises the other cerebral hemisphere and has a compression effect on it, and then the patient can develop altered mental status. So for coma requires dysfunction of either the pontine reticular activating system or bihemispheric cerebral dysfunction. Unilateral cerebral hemispheric dysfunction usually does not give rise to coma. Now the level of arousal or consciousness. Conscious means alert, attentive, and cooperative, who is aware of self and the surroundings. Confused. Patient is conscious, but he talks irrelevantly. His answers are not coherent, and he is fluent but not coherent. Drowsy. Patient is sleepy, but you can arouse him by external stimuli. What is a stupor? Difference between drowsiness and stupor. Stupor is deep sleep. He can only be aroused by painful stimulus, and once the stimulus is removed, the patient again goes in the same state. What is coma? Unconscious, no response to external stimuli. So these are different terms used in the patient with altered mental status. Now, how do we assess level of consciousness? There are several scales which have been designed to assess altered level of consciousness, which include Glasgow Coma Scale, Avpu score, Coma score of 4. Among these scales, GCS or Glasgow Coma Scale is the most commonly used scale. Avpu is a simpler one. Now, what is Avpu scale? A stands for alert, which assess alertness of the patient. He is awake, he is alert. Now, verbal, patient responds to verbal stimulation. Pain, responds to pain. Unresponsive, the patient is completely unresponsive. So these are 4 responses that we assess in the Avpu scale. Then comes the GCS, Glasgow Coma Scale. Now, Glasgow Coma Scale has basically 3 components. We assess 3 types of responses in a patient of coma using Glasgow Coma Scale. The minimum score is 3 and the maximum is 15. In a conscious patient, oriented patient, the GCS is 15. Now we have to assess the best eye response. When the eyes are opening spontaneously, we give it a score of 4. Eyes are opening to speech or a verbal command, the score is 3. Eyes are opening in response to a painful stimulus, the score is 2. And when there is no eye opening, the score is 1. Similarly, in verbal, there are maximum 5 points and minimum 1. 5 is oriented person with coherent responses. 4 is confused person. He is responding, but he is disoriented. 3 is inappropriate words. The words he is producing, but these are inappropriate. 2 is incomprehensible sounds, and 1 is no response. In motor response, the maximum score is 6 and the minimum is 1. With a score of 6, the person is obeying commands. When the person obeys commands, we give it a score of 6. When he localizes to pain or painful stimulus, that is given a score of 5. When he withdraws from the pain, he doesn't localize to the pain, but he withdraws from the pain, that is a score of 4. When there is flexion in response to pain, he flexes the arm in response to pain, that is 3, score 3. Extension to pain, there is extension of the extremity in response to painful stimulus, that is a score of 2. And if there is no motor response, we grade it as score 1. Glasgow's Coma Scale, individual element as well as the sum of the score are important. Now let me give you an example. For example, a patient comes who has left MC infarction. Okay, his speech area is disturbed. He is dysphasic. Maybe he has global aphasia, or maybe he has comprehension issues. Somehow there is motor weakness is there, but his verbal response is also decreased. And the DCS comes around maybe 8 or below 8, but he is apparently awake. Patient is conscious. His verbal response is diminished because of the speech area affected by the stroke. And motor weakness is there. So it can be severe weakness, it can be moderate weakness. So in this patient, we cannot say that he is comatose. We can simply say that he is conscious, but he's probably dysphasic or aphasic, whatever. So these are some technical issues that come when especially we are dealing with patients who have strokes or some other vascular events. Basically, Glasgow's Coma scale was designed for patients with trauma, but now it is generally being used. But there are some problems in applying DCS in neurological patients, as I have explained one issue in stroke patients. Now, generally, the score is expressed in the form of DCS, like if I response is 2, verbal is 4, and M motor is 3, we write it as DCS 9 is equal to E2, V4, and M3. This is how we write it. Now the comas are classified as severe coma, DCS less than 8, E2 less than 8, moderate is 9 to 12, and mild is around 13 or more than 13. We consider as it mild. Now come to differential diagnosis of coma. Let me tell you one thing, that all coma patients don't have an underlying neurological pathology. All comas are not due to neurological problems. There are multiple causes of coma, and among those, neurological causes are one, and we have a lot of other causes. Let's see. We have categorized it in 3 types of syndromes. One is no focal neurological signs. CT and CSF are normal. This is one category. Then comes the other category. We have focal neurological signs with or without changes in the CSF, CT and MRI are abnormal. This is second category. And the third, we have categorized it meningitis syndromes. Meningitis syndrome with an excess of WBCs in the CSF, usually without focal signs, maybe focal signs, or CT and MRI show no mass lesion. Okay? So these are basic 3 categorizations that we have done to simplify it. And now come to the diseases without focal neurological sign. Diseases that cause no focal signs, they usually with normal brainstem function, and usually the CT and CSF is normal. And those include metabolic disturbances like hypoglycemia, hyponatremia, and hyperglycemia, non-ketotic hyperosmolar states, even hypercalcemia is one of these, and Addisonian crisis. And then we have intoxications like alcohol overdose, like overdose of sedatives, antidepressants, opioid, and even in severe systemic infection. Infection is not directly involving the brain or the nervous system, but as a secondary effect, patient is in altered mental status. It can occur in malaria, occur in sepsis of any cause, and shock of any cause. It can also lead to altered mental status and post-seizure states like post-ictal states and status epilepticus. And third is non-convulsive status. What is this terminology? This indicates that the patient is having subclinical seizures with no apparent motor activity visible, no apparent gross motor activity visible. They may have nystagmoid jerks of the eyes, or they may have twitching of face or one extremity mild off and on, but the underlying uh, electrical seizure activity is continuing. So that is called as non-convulsive status epilepticus. Hypertensive in calf, that is one. And we have severe hypothermia and hypothermia, and these are also the cause of coma without or focal neurological signs. Then we have diseases which can have focal neurological signs. Now they can have localizing signs with or without changes in the CSF, and CT and MRI are abnormal. What does these diseases include? Like CNS vascular disorders, hemorrhage or infarction, brain infections like space occupying lesions like abscess, and maybe subdural empyema, brain tumor with surrounding edema, brain trauma leading to epidural and subdural hemorrhage, contusions, diffuse axonal injuries. Then we have metabolic comas. They may have pre-existent focal damage, like, for example, a patient has come with hypoglycemia, but he has stroke in the past. So he may have residual old focal signs, but the current problem is hypoglycemia. That's why the patient is in coma. So this explains the focal signs. Even hypoglycemic patient per se can have focal signs sometimes without a stroke, old stroke, new stroke. Miscellaneous causes are cerebral venous sinus thrombosis, we have herpes encephalitis, and sometimes there are septic emboli due to endocarditis and cerebral vasculitis. These are some of the causes. Then we come to meningitis syndromes, diseases which cause meningeal irritation with or without fever or with an excess of WBC or RBC in the CSF. Usually these are without focal or lateralizing cerebral brainstem sign, and CT or MRI shows no mass lesion. Now remember this, CT or MRI shows no mass lesion, but there may be abnormalities. Okay, so now the meningitis, it can be inflammatory meningitis like we have in subarachnoid hemorrhage. What happens in that? There is chemical meningitis, there is blood in the subarachnoid space, which is giving rise to signs of meningeal irritation, but it is not infective meningitis. Now the infective causes, we can have acute bacterial meningitis, even viral encephalitis when it involves the meninges in the form of meningoencephalitis. It can give rise to signs of meningeal irritation in a patient. There are certain other different meningitis like carcinomatous, lymphomatous, and these also comes under the meningitis syndrome. Now, how do you approach a patient with coma? First of all, we have to start with A, B, C. A for airway, B for breathing, and C for circulation. Now, airway, GCS less than 8, intubate. But you have to take the entire clinical picture into context. Before intubating the patient, please check his blood sugar. If he is hypoglycemic, you can give him 25% dextrose, 50% dextrose, whatever is available, and you can wait for the response. So this is one important thing. Now, in the absence of other indication, defer intubation until hypoglycemia and opioid toxicity have been excluded. You have to rule out opioid toxicity as well. What happens in opioid toxicity? You will get pinpoint pupils and you will get respiratory depression, and patient can be comatose. So what you need to do, you need to give an antidote. For example, you will check blood sugar, that is normal, but patient has respiratory depression, pinpoint pupils, you are suspecting opioid overdose, you should give naloxone, and patients, they usually respond. So it can defer the intubation. Then we have to maintain the cervical spine collar if history is unknown, especially if the history is unknown, patient is brought by some ambulance or some place without the attendants or somebody who lives with him, then you have to consider that he may have sustained cervical spine trauma. And if you don't stabilize the spine, when you examine the patient, when you do the maneuvers, you can destabilize it and you can cause permanent cord damage. Now breathing. Breathing, you have to assess the presence and the adequacy, the respiratory rate, the pattern of breathing, high concentration oxygen immediately in all patients with decreased level of consciousness, and you have to assess if respiratory or tidal volume is adequate. Now come to the circulation pulses. You have to see the volume of the pulse, the rate of the pulse, if it's bradycardic, tachycardic, perfusion, if the extremities are cold and the patient is tachycardic, it is probably showing hypovolemia due to some internal or external bleeding or dehydration. Is there any evidence of bleeding, like when you put the NG tube, are there coffee grounds in there? Are the patient's nose sustained with blood? Are there any external injury marks? So this is how you assess the circulation. Now the immediate management, you have to maintain IV line with oxygen inhalation, take the blood sample for blood sugar and other relevant investigations. And if you are suspecting intoxication, then you have to send blood and urine for drug screening as well. You have to control seizures if any, and you have to consider IV thiamine followed by glucose. Now that is very important. If a patient arrives in ER, you are not supposed to give glucose directly. And you have to give IV thiamine first followed by glucose, because it can precipitate the neurological damage if you administer glucose first and thiamine later. If there is underlying thiamine deficiency, and that is Very much true for the alcoholics. They do have thiamine deficiency, and if you administer directly dextrose without giving thiamine, it can cause permanent neurological damage. Naloxone, as I have already discussed in context of opioid overdose, and flumazenil if you have very clear-cut history of isolated benzodiazepine overdose. Then there is a coma cocktail, which you can remember with the mnemonic of DON'T. D stands for dextrose, O for oxygen, N for naloxone, and T for thiamine. Always remember thiamine first, then dextrose. Okay, and flumazenil, there is a question mark because if you don't have clear-cut history of benzodiazepine overdose, isolated benzodiazepine overdose, and if the patient is taking some other thing along with benzodiazepine like TCA, so it can worsen the problem. Now your attention should be directed toward assessment of the patient. You assess the GCS scale, Glasgow Coma scale, and then you start a diagnostic evaluation. All possible information should be taken from the relatives, from the paramedics, from the ambulance personnel, and from the bystanders, particularly about the mode of the onset. History. History is very, very important whenever you are assessing any patient, whether in the ER, whether in the OPD. History is the foundation and base of your diagnosis. So you have to assess in which circumstances and rapidity with which the altered mental status developed. For example, if it is sudden, very much sudden apoplectic onset, this is very much likely some vascular etiology. May it be seborrheic, may it hemorrhage, may it be intracerebral hemorrhage, may it be stroke. And if the patient has any antecedent symptoms like confusion, like weakness, like headache, fever, any history of seizures, any history of dizziness, double vision, vomiting. Now, what would you conclude from this? If the patient has headache, fever, vomiting, maybe he has some CNS infection. If the patient has double vision and vomiting, maybe he has raised ICP because of any underlying pathology. And if he's confused and gradually becomes comatose, maybe there is some underlying metabolic disorder. And the use of medication, drug history is very important. History of alcohol intake is very important. And you need to ask the relatives and the attendants about patient having any chronic liver, kidney, lung, heart, or any other medical disease, because worsening liver function, worsening kidney function, worsening COPD, and cardiogenic shock, these can all lead to altered mental status. Now you have to get clues obtained from patient's clothing or handbag, especially when the relatives are not available. You have to carefully examine for injury marks, and it needs complete exposure and log roll to examine the back. You have to look for the needle marks in context of IV drug abuse and maybe infective endocarditis. If head trauma is suspected, the examination must await adequate stabilization of the neck. GCS severity is essential for subsequent management. Following this, you have to pay attention to the brainstem and motor function. Okay. Now, general examination, as we have discussed, pulse. Bradycardia can occur with raised ICP, for example, due to brain tumors. Opiates can cause bradycardia. Myxedema, hypothyroidism can cause bradycardia. Tachycardia can be due to hypovolemia, shock, sepsis, blood loss, hyperthyroidism. BP can be high in hypertensive in CAF, and it can be low in MI, sepsis, and Addisonian crisis, and barbiturate poisoning. The temperature is very important. Fever that can occur in sepsis, meningitis, encephalitis, even heat stroke, and anticholinergic drug intoxication. Hypothermia, it may be due to myxedema coma. It may be in alcoholic patients. It may be present in peripheral circulatory failure, shock, hypoglycemia. Respiratory rate, tachypneic. Patient, if he is tachypneic, he may have acidosis or he may have pneumonia. And if there is aberrant respiratory pattern like apneustic breathing or chest strokes breathing, so that may be in brainstem disorders. Now, general examination is also very, very important. You have to look for injury marks like bruises, traumatic causes. You have to look for dry skin, which can occur in decay and atropine, and moist skin and hypoglycemic coma, cherry red skin and CO poisoning, and needle marks in IV drug abuser, and maybe an indirect clue for infective endocarditis, rashes like you get in meningococcemia, and even endocarditis, and sometime in TTP thrombotic thrombocytopenic purpura. These patients can also have rashes, purpuric rashes. General examination, order of breath. Acetone breath, like that may be in decay, present in decay. Fetal hepaticus, that sort of breathing order is present in hepatic coma. Uriniferous order can be in uremic coma, and alcoholic intoxication. Now the level of arousal. How do you start assessing the patient for the level of arousal? First of all, you have to call him with his name or with a simple verbal command to get up or to open eyes. If he doesn't respond, then you go tickling the nostrils with a cotton mist. It's a moderate stimulus to arousal. Pressure in the knuckles or the bony prominence and the pinprick, they are human form of noxious stimuli. And pinching skin, it causes ecchymosis. It is generally not necessary, but sometimes it is useful in eliciting the abduction withdrawal movement of the limb, because sometimes you may see that when you give a painful stimulus, you can see the movement of the upper limbs, but you're not sure whether the motor power in the lower limb is normal. So you may pinch some muscles and see if he withdraws. Now posturing. There are basically two types of rigidities: decorticate rigidity and decerebrate rigidity. Now what is decorticate rigidity? Decorticate rigidity is flexion of the elbows and wrist and supination of the arm, and it indicates bilateral damage rostral to the midbrain. And decerebrate is extension of elbow and wrist with pronation and indicate damage to motor tract in the midbrain or caudal diencephalon. So this is decorticate rigidity. Here you can see flexed arms. Okay, this is internally rotated, plantar is flexed, this is flexed, this is adducted. Okay, so this is decorticate, and this is decerebrate, this is adducted, extended, pronated, and this is flexed. Plantar is flexed, this is decerebrate rigidity. Now come to brainstem reflexes. The brainstem reflexes, these are very important when you are assessing a patient of coma. And what do we assess? We look for pupillary reflexes, we look for ocular movements, corneal reflex, and respiratory pattern. As a rule, coma due to bilateral hemispheric disease preserve these brainstem activities because hemispheres are damaged but brainstem is intact. Pupils. This is an important general rule. Most metabolic encephalopathies give small pupil with preserved light reflex. Pupils are small but reactive. And if atropine and cerebral anoxia, they tend to dilate the pupil, and opiate will constrain. Opiate poisoning, small pupils. Now beware of drug effects. Drug effects, it can be systemic, like for example benzodiazepine, they usually give you small pupil, and local like mydriatic, which some ophthalmologists put mydriatic in the eye to examine the fundus clearly. If someone has put eye drops in both eyes, you may get fixed dilated pupils, and you may falsely think that a patient has mid-dilated pupils and fixed and non-reactive, but actually it is due to drug effect. And avoid writing parla, that is pupils are equally reactive to light and accommodation. Always state the size before and after light stimulation, and you have to specify right and left separately. Regarding eye movements before maneuvers, note the resting position. How do you note the resting position in a patient who has closed eyes? You have to just lift the eyelids with your hand, and you have to see position of the eyeballs, if these are midline or not. And if there is deviation from the midline, eyes are deviated to one side, either the right or the left. There may be damage to frontal or maybe pontine damage. Either it is a frontal lesion or it is a pontine lesion. If there is disconjugate, like one eye is deviated and one eye is midline, it means there is some cranial abnormality. And if the eyes are roving and moving side to side, it usually means that brainstem is intact. And then again come to the conjugate deviation of eyes. When the eyes are deviated to one side, either it is ipsilateral hemispheric lesion, frontal lobe, or there is a contralateral pontine lesion. When there is downward conjugate deviation of the eyes, there is midbrain lesion. And when there is disconjugate ocular deviation, there is a brainstem lesion with cranial nerve involvement. Now we come to ocular cephalic or caloric testing. These are the same reflex tested with different methods. We will talk about oculocephalic or doll's eye reflex only. This is the same reflex, and afferent is through the 8th nerve, that is the vestibulocochlear nerve, and efferent is through the 3rd, 4th, then 6th nerve through the medial longitudinal fasciculus and the pontine reticular formation. Oculocephalics may also involve proprioceptive afferents from the neck. Now what do you do? Brisk rotation of the head with the eyes held open, and you have to watch for contraversive movement. And next, flexion, eyes deviate up and eyelid open. doll's head phenomena occurs and extension, eyes deviate downward. When you flex the neck, the eyes deviate up and eyelids open, and you extend the neck, the eyes deviate down. As you can see here, eyes move from side to side when the head is turned, and abnormal reaction, eyes remain in fixed position when head is turned. So this is abnormal. This is absent doll's eye reflex. The upper one is normal. Eyes are moving opposite to the side of the head. That is doll's eye reflexes. Ocular cephalic reflex or doll's eye reflex is intact. Now come to corneal reflex. The afferent goes through the trigeminal nerve, efferent through the facial nerve, and it tests the pontine integrity, as you all know. Fifth cranial nerve and the seventh cranial nerve, both nerves, their nuclei lie in the pons. Now gag reflex, the afferent is through the glossopharyngeal and the efferent through the vagus, and taken in context of other findings. Breathing. Now abnormalities of respiration can help localize, but almost always in the context of other signs. Now see, there is central reflex hyperpnea. What happens that if when there is midbrain or hypothalamic lesion, patient they may have hyperpnea, increased breathing, increased rate of breathing, and there may be apneostic or ataxic breathing, which indicate lower pons damage. And apneostic, what does it mean? There is apnea in between, apneostic pause. The patient inspires and there is an apneostic pause, and then again he inspires. And ataxic, there is breathing, normal breathing or rapid breathing, and then there is a pause. And loss of automatic breathing, that is due to damage to the medulla. Now the apneostic breathing, brainstem pons may also give with a pause at full inspiration, and when it, as I have told you, the ataxic breathing, and then it's medullary lesion, which have irregular respiration with random deep and shallow breathing. Now come to motor function. In motor function, your particular attention should be directed toward asymmetry of tone or movement. The plantars are usually extensor, but asymmetry is again important. It gives you clue that the lesion is unilateral. Tendon reflexes, these are less useful, and the motor response to painful stimuli should be assessed carefully. That is part of GCS. Painful stimuli, you have to give supraorbital nerve pressure or nail bed pressure, and rubbing of the sternum, it should be avoided because it can cause bruising and it can distress the relatives. Patients may localize or they can exhibit a variety of responses, and you have to look for symmetry or asymmetry of this localizing or withdrawal response. For example, if you give nail bed pressure or supraorbital ridge pressure, and if the patient, he localizes with the right hand, but if you hold his right hand, he should localize with the left hand. But if he doesn't, it means there is weakness on the left side. Okay, so you need to look for localization with both sides. Even same is true for the withdrawal. Now the motor function, flexion, again this is probably a repetition of the GCS. And flexion of the upper limb with extension of the lower limb, that is decorticate, decerebrate, we have already discussed. You can see here in the topmost he is seeing following commands, then he is localizing in the second, then withdrawing in the third, and flexion response in the fourth, and lower down comes the extensor response, and then no response. No response is 1, extensor is 2, flexion is 3, withdrawal is 4, localizing is 5, and following command is 6. Now signs of lateralization. Unequal pupils, one is dilated, one is normal. Okay, it may indicate herniation. Deviation of eyes to one side, as I've already described. If deviation of eyes is to one side, it means either there is ipsilateral hemispheric frontal lobe lesion or lateral pontine lesion, facial asymmetry. It also indicates focality. It may be in the hemisphere or it may be in the pons. If it is in the pons, the signs have to be crossed. Facial asymmetry of one side and paralysis on the other side. If this hemispheric problem, it will be upper motor neuron type facial weakness. So facial and body weakness has to be on the same side. Now turning of the head to one side may indicate probable seizures. Unilateral hypo or hypertonia again will indicate a unilateral, either a mass lesion or a vascular lesion. Deep tendon reflexes asymmetry. One side there's a normal or diminished, other they are hyper. Again indicating some unilateral lesion, maybe in the brainstem, maybe in the supratentorial compartment. Unilateral extensor plantar response, it may indicate a unilateral cortical or brainstem lesion. And unilateral focal seizures, again, it is signifies unilateral cortical lesion. Then we have to look for signs of manual irritation, which include neck rigidity, Crohn's, and Brudzinski. What do you do in checking neck rigidity? You have to hold patient's head laterally and you should flex it. Okay, if it is resistant to flexion, the patient winces or it shows resistance, that is positive neck stiffness. And Brudzinski, when you flex the neck, both knees flex. That is Brudzinski is positive. And Kernig's, how do you do it? You flex the knee, you flex the hip, and then you extend the knee. And if the patient winces, gives the expressions of pain, Kernig's signs is positive. Now head and neck. As I've already told you about the stabilization of the cervical spine, regarding the head, you have to look for evidence of injury. Skull should be palpated for depressed fractures. Ears, nose, regarding hemorrhage or some leakage of CSF blood. Fundi, you have to look for retinal hemorrhages, maybe diabetic, hypertensive changes, retinopathy changes, or especially for papillary edema. Now we come to diagnostic testing, labs. Now it will depend on your history and the total assessment. You cannot send each and every test in all patients, so at least you should obtain the ABGs, the serum electrolytes, glucose, creatinine, complete blood count, LFTs, and urine DR in each and every patient, drug levels ordered if appropriate, and toxicology, screen of blood urine if suspected. Imaging head CT always to look for structural abnormalities, and brain MRI can be useful if it is non-diagnostic and if you are suspecting that there is some ischemic or maybe some parenchymal lesion, especially posterior fossa lesion, especially the lesions in the brainstem, in the cerebellum. Sometimes you may not be able to define them on a simple CT, so it would be better to go for MRI. Now diagnostic procedures, CSF examination. And lumbar puncture is considered with fever or maybe a new onset headache. And fundus examination and head imaging, CT scan prior to LP to assess the risk for herniation. If there is significant brain edema and the patient is having papillary edema, you have to be very, very careful regarding lumbar puncture. And if the CT is showing a unilateral lesion with a mass effect and signs of herniation, LP is contraindicated. Now you have to send CSF for basic CSF studies like protein, glucose, cell count, staining, and cultures, often with additional studies depending on the possible etiology. EEG is sometimes very useful to rule out disciplinary seizures, and as I've told you, non-convulsive status, it is a common cause of unexplained encephalopathy in the critically ill patients. These are few ECG waves: alpha, beta, theta, delta. Delta is abnormal in an awake patient. If the patient is altered, he may have diffuse slowing, that is delta activity. Alpha is the normal rhythm, posterior alpha rhythm. Prognosis. Now the prognosis in general, coma carries a serious prognosis. This is dependent to a large extent on the underlying cause. If the patient has simple hypoglycemia, he's brought early, you give him dextrose and he's all good. So again, it depends on the cause. In coma due to depressant drug, it also carries an excellent prognosis, provided that he is managed timely with resuscitative and supportive measure and there is no brain anoxia till the patient is brought to ER. And metabolic causes apart from anoxia, they carry a better prognosis than structural lesion and head injury. Now the length of coma and increasing age, these are both prognostic significance. The sooner the patient is brought for assessment, the better are the chances of early diagnosis and management. And brainstem reflexes early in the coma are an important predictor of outcome. If the brainstem reflex is absent, usually the prognosis is poor.